Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, Brian. Thank you for that intro. Hello, everyone. Thank you for having me. And I am going to be sharing some of the abstracts from ID Week 2020, just the other week. As you can imagine, there were many abstracts that were interesting, but I actually thought that we'd do a little theme for today. And the theme that I've chosen is some concepts that come up in HIV primary care that I suspect many of us deal with on a daily basis. And so I thought I'd share some of those. So I have no disclosures, and an outline of the three abstracts that I'll be reviewing today include one about lung cancer screening in people with HIV, another one about practice patterns in Hep B vaccination for people with HIV, and then discussion about use of the vaccine Heplisav for people with HIV as well. So first off, lung cancer screening. As a bit of background, I think many of us know that in 2013, the USPSTF recommended low-dose CT chest for those that were aged 55 to 80 with a 30-pack year smoking history, who currently smoke or who have quit within the past 15 years. And compared to the general population, people with HIV have an overall increased risk of cancer and higher rates of lung cancer in particular as well. And so though we know that the USPSTF guidelines may not be applicable to people with HIV, and people have certainly looked into this and continue to do so, this one particular study decided to look at lung cancer screening rates in general. And so this was a retrospective chart review of patients aged 55 to 80 at a Midwestern HIV clinic between July 2016 and June 2018. Of 341 patients in their cohort, 256 were included in the analysis as eligible for lung cancer screening based on the USPSTF criteria. And they excluded that sort of 91 or so individuals if they had never smoked, were deceased, had an unknown pack year history, or had already had a primary diagnosis of lung cancer. And so in their cohort, the mean age was 61, 75% were male, and they found that 41% met USPSTF criteria for lung cancer screening among these people who smoke, but only 13% of those who met criteria were actually referred for low-dose CT chest. Of those, 55% who were referred actually completed the referral. There's not much else to this abstract. It was sort of based on a poster, and there's some numbers that I wished they had included but weren't included, but that is sort of the big takeaway. Interestingly, patients who received tobacco cessation counseling and those who actually had Hep C as well were more likely to receive a lung cancer screening referral. However, they postulate they don't really know why that's the case, especially with hepatitis C, though they did postulate that perhaps it makes sense that when you're talking about tobacco cessation, then you may be more likely to bring up this screening recommendation. So in summary, as I mentioned, it was a short study. In a small single-center HIV clinic, only 13% of people with HIV who smoke who met USPSTF criteria for lung cancer screening were referred for low-dose CT chest, and approximately half of those completed the referral. So my take-home point here is that lung cancer screening rates are low, and that this is a reminder to assess for USPSTF lung cancer screening criteria in all patients who smoke, and remember to refer if appropriate. As I mentioned, this isn't the most sort of statistically robust study, and as I sort of pointed out a limitation, it is a small single-center study. However, I think this is something that we all need to probably improve upon. I think sometimes I forget that patients smoke. If it's not on the problem list, it's not something that I remember all the time. And I think it's because smoking is so prevalent amongst our patient population as well. And so I thought that I could share this and hopefully impact in a positive way some of our referrals for people who need lung cancer screening, especially for something that could potentially be caught early and have favorable outcomes. So that was the first one. Then the second abstract is about practice patterns in hepatitis B vaccination for people with HIV. I believe in the month of December that Dr. Nina Kim will be sharing some stories about hepatitis B that came from Madison Clinic, and we have definitely been seeing a resurgence of hepatitis B, unfortunately. And so I thought that it might be timely to review two of these studies and sort of hopefully have some discussion about them at the end. So this first study was just looking at practice patterns. And the reason why they did this is that we know that individuals with HIV and Hep B co-infection have higher rates of liver-related mortality compared to individuals without HIV. And we're also aware that HPV vaccine response rates in people with HIV are significantly lower, ranging from 18 to 71%, as compared to adults without HIV, ranging from 60 to 80%. As I mentioned, HPV transmission continues to occur, and I think this is a topic of particular importance, especially as we begin to prescribe more NRTI-sparing regimens. Right? As we use less TDF and FTC and even 3TC, we are essentially almost removing Hep B PrEP, and so thus we may be sort of exposing patients to new cases of Hep B or potentially Hep B reactivation. And so I think it's really, I wanted to bring this up, especially as we sort of enter that era a little bit more. So what they did was that they wanted to evaluate current HPV screening, vaccination, and monitoring practices of physicians caring for people with HIV. What they did was a web-based survey with 2 sets of case-based questions that was disseminated to the ID division at UC San Diego, which is where the study was based, the IDSA, or the Infectious Disease Society of America, and social media networks. So they posted this onto Facebook and Twitter. And I don't know if others participated in this, but I actually now remember having filled out their survey, and it was quite long. The study participants were 74 clinicians from 26 states who responded. And on average, 55% of those clinicians saw greater than 20 people with HIV per month, and 73% of them worked at academic medical settings. And what they found are a series of tables that I'm going to take us through that I think are just interesting to see how other people practice. So the first question was what the preferred timing of HPV vaccination in a patient newly diagnosed with HIV getting started on ART was. 78% of individuals vaccinated immediately. 19% of individuals postponed vaccination until the HIV viral load was suppressed. 1% deferred vaccination since the patient is on ART. This is exactly what was written on the poster and doesn't really make much sense to me. And then 1% did something else. And so I think I just wanted to share that I think good to see that a majority of people are sort of vaccinating as soon as possible, especially in a cohort of individuals who are at higher risk potentially for Hep B. And then when they were asked what they decide to vaccinate with, they looked at the sort of preferred initial HPV vaccine series for susceptible people with HIV. They found that 29% of people are using Hendrix or Recombavax, 42% of people are using Heplisav-B, and 29% are using any of the above, doesn't matter. So takeaway from that was that the majority of people, or I guess 42% of people are using Heplisav-B, but there is some practice variation there. Interestingly, they also asked about what people do with people who have not responded to the hepatitis B vaccine. So I'll take us through this. So the 6% of individuals didn't do anything else. 22% of individuals repeated the series, standard dose at 0, 1, and 6 months. So they just did it another time. 28% actually repeated the same sort of vaccine, but used a double dose with the same timing. 3% of people repeated it with an extra dose, which is also something that has been studied in people with HIV. Nobody did a double dose for 4 doses. And 42% of people repeated with Heplisav instead of the Hendrix or Recombavax. All this to say that, again, 42% of people repeated with Heplisav and approximately 50% of people repeated with the same vaccine, either at the same dose or at a double dose. But this is a pretty big spread. And then also they asked about what people do with an isolated Hep B core antibody. 22% of people said that they did nothing else. 24% of people said that they initiated Hep B vaccination. 9% gave a single dose of vaccine and checked a titer a month later, and 45% of people checked a Hep B virus DNA level. So my summary for this slide is that in this survey study of 74 clinicians who care for people with HIV, there was significant practice variation regarding HPV vaccination, antibody monitoring, and management of a positive isolated Hep B core antibody. And it appears that practitioners are interested in using Heplisav-B. So my take-home point is that there does not appear to be a standard approach to HPV vaccination among those who care for people with HIV. And I think at the very least, despite that sort of practice variation, we can all agree that we need to be vigilant in checking Hep B surface antibody at least 1 month after vaccine series completion. That is oftentimes something that I notice people forget, and I think it's important, especially in this time, as I've talked about, especially as we're going towards nuke-sparing regimens, that we need to make sure that people are immunized against hepatitis B. So I mentioned Heplisav, and so thus I wanted to talk a little bit about that. Heplisav is a 2-dose recombinant HPV vaccine with a novel immunostimulatory adjuvant, which was FDA approved in 2017 for adults 18 years and older. In immunocompetent adults, seroprotection with Hendrix-B or Recombavax, the older Hep B vaccines, range from 65 to 80% versus 90 to 95% with Heplisav-B. And again, as a reminder, the previous regimens were 3 doses, 0, 1, and 6 months, whereas Heplisav-B is just 2 doses. And although many have adopted use of Heplisav-B, it has not been studied in people with HIV. So this was a retrospective cohort of 51 people with HIV greater than 18 years of age without a current HPV seroprotection, i.e. they looked at their most recent anti-Hep B surface antibody, and it was less than 10. And their primary outcome was looking at seroprotection rates at any point following the first Heplisav-B injection. What I forgot to mention is that this actually took place at an academic HIV clinic in San Francisco. The study population was generally of an older sort of cohort of individuals ranging anywhere from age 48 to 66 with a mean age of 59, with very good virologic suppression. 96% of this, again, small study population had virologic suppression, less than 200 copies per milliliter. Mostly were male and mostly were white as well. Results they found were that 50 of 51 individuals received both doses of the Heplisav-B vaccine, and 1 of 51 received 1 dose. The seroprotection rate was 42 out of 51 at 82%. They looked at multiple variables as well and found that there was no significant difference in SPR, or seroprotection rate, based on age, sex, race or ethnicity, BMI, CKD, diabetes, smoking status, immunosuppression, non-HIV immunosuppression to be particular, prior HPV vaccination, history of prior surface antibody or core antibody, or based on their viral load. But the one thing that was statistically significant was their CD4 cell count and the nadir and current CD4 cell count. So they found that higher CD4 cell counts were associated with seroprotection, which I don't think is particularly surprising. It makes sense, but I will take us through these graphs. On the y-axis, we've got the seroprotection rate, and on the x-axis, we have the CD4 cell count. On the left, we have current CD4 cell count, and on the right graph is the nadir CD4 cell count. And as you can see, the further towards the right we go, as people get higher CD4 cell counts, that their seroprotection rate goes up. And the sort of values that they found were 92% for current CD4 cell count and 100% for nadir CD4 cell count, the higher it was. So in summary, this was a small single-center retrospective study of predominantly virally suppressed men in which safety data was not systematically collected. So they didn't really look at that. They just looked at these results. And they concluded that seroprotection rate after Heplisav-B in people with HIV may be comparable to those without HIV, and that higher CD4 cell counts were associated with higher seroprotection. So my takeaway point from this was that although Heplisav-B led to a higher seroprotection rate in this small cohort of people with HIV, Heplisav-B has not actually formally been studied in people with HIV and will be soon. There will be an ACTG study called the Beehive study, sort of across the nation, that will be looking at vaccine response rates in people who do not have seroprotection and they get Heplisav-B. And so more information will come on that at some point. And so I just wanted to sort of open up for discussion because I thought that these were really interesting sort of studies that were at least thought-provoking, although they were small. And so I just put some of the conclusions up here again so we could be reminded that, again, lung cancer screening rates among people with HIV were low, that approaches to HPV vaccination are varied, but we should be checking surface antibody levels a month after vaccine series are completed, and that Heplisav-B has not actually been formally studied in people with HIV, though will be soon. So I wanted to open it up to the crowd to see if people had thoughts or comments.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.